morning everyone, I'm Dr. Aman. I'm a fellow at Oculoplasty and Ocular Aesthetic Services at Visionary Centers, New Delhi under Dr. A.K. Grover sir. I'm extremely thankful to Dr. Rituja ma'am and Dr. Grover sir for giving me this opportunity to share the dais with the stalwarts in the field of ophthalmic plastic surgery. I'll start with my presentation on flaps and grafts now. So we'll be covering the presentation under the following heads. So what are the basic goals of reconstruction? The basic goals of reconstruction are basically for the functional rehabilitation and the cosmetic rehabilitation. What is the reconstruction ladder? So this is a very important concept which is followed by all the reconstructive surgeons around the globe, and it is a 4-step process which involves direct closure, which involves suturing and the healing with secondary intention, autologous skin grafting, which involves split thickness or the partial thickness skin grafting, followed by the loco-regional approach which includes the pedicle flap, and final stage being the free flap. So coming back to the basics, what is the difference between grafts and flaps? So graft is a tissue which is harvested from a donor site which does not have its own blood supply, and it depends on the recipient site for its blood supply. On the contrary, flaps are the tissue which are harvested and they carry the blood supply on their own. Important differentiating feature is cosmetically, grafts may discolor or contract, but flaps, they have a better color uptake and less likely to contract. So what is the basic principles of reconstruction? We need to restore the like tissue for the like. Remember the basic principle: graft when laid on a flap, flap when laid on a graft, and flap when laid on a flap. All three have a very well post-operative outcome, but a graft on a graft reconstruction has a high failure probability because of the lack of the vascular supply. Coming on to the relevant anatomy. So we'll be covering it under the following heads of external eye examination, relaxed tension lines called as a Langer's line, and anatomy of the eyelid. So this is a diagram showing the horizontal palpebral aperture which measures between 28 to 30 mm lying between lateral canthus to medial canthus. Vertical palpebral aperture, also called as the palpebral fissure height, is somewhere around 9 to 10 mm. So this is a slide showing the anatomy of the eyelid. So the major differentiating feature between the upper eyelid and the lower eyelid is the presence of the capsulopalpebral fascia in the lower eyelid, which is replacing the LPS muscle present in the upper eyelid. The most important concept being a reconstructive surgeon is the presence of the gray line, as we all know, which is the junction of the skin and the conjunctiva. It divides the intermarginal strip into the anterior lamella, which is nothing but bearing the skin and the eyelashes, and the posterior strip, which consists of the opening of the meibomian glands. Now this is a slide showing the relevant vascular supply around the orbit. Important is the presence of the superficial temporal artery, as one of the named island flap is based on this superficial temporal artery. What are Langer's lines? So these are the relaxed tension lines. These are the preferred direction of the skin incision in the facial region. They lie parallel to the natural orientation of the collagen fibers in the dermis. They forms an aesthetic scar and avoids the gaping whenever the incision is given along these lines. Now, assessment of the eyelid defects to be reconstructed. In our clinical scenario, we can have an eyelid defect which can arise either from the traumatic setting. In the second image as shown is the congenital coloboma, and after the iatrogenic cause like the tumor resection. Sticking to the nomogram for the lid defect affair as being practiced around the globe by all the reconstructive surgeons, lid defects can be classified as either the full thickness margin involving defects or only the anterolamellar defects. Anterolamellar defects, depending on the size of the defect, can be closed either with the primary closure or by the skin grafting and the flaps. On the other hand, full thickness margin involving defects can be again further classified on depending on the amount of the tissue loss as small defects, medium-sized defects, or the large defects. What are the common grafts in the ophthalmic plastic surgery? These are the skin grafts, which can be full thickness or partial thickness, cartilaginous grafts including the hard palate grafts, mucosal grafts, amniotic membrane grafts, and composite grafts. So sticking to the basic principle of stages of the graft uptake, so this involves basically 3 stages. That is the imbibition stage, which is lasting for 24 to 48 hours. Second stage is inosculation and capillary ingrowth stage, which ends in about 48 hours. And the final stage being the revascularization stage. So importantly, a graft needs at least 4 to 7 days, and only after that we can tell about the outcome of the graft procedure. So coming to the skin grafting, it can be divided as full thickness skin grafts or split thickness skin grafts. In ophthalmic plastic surgery, eyelid reconstruction, better suited is the full thickness skin grafts. And this is the image showing what are the common sites we can harvest the grafts. It can be a contralateral eyelid skin from the preauricular or the postauricular area and the supraclavicular area. Now coming on to the next is label mucous membrane grafting. This is done in cases of inferior eyelid retraction associated with lower fornix contraction. The important point to ponder is we need to harvest the graft at least 1 centimeter away from the vermilion border to prevent the scarring and contracture of the lip. Hard palate graft, this is the type of cartilaginous graft. Important site for the graft harvesting is the canine premolar area, which is approximately 8 to 13 mm from the mid-palatal aspect. Going beyond 13 mm will lead to a damage to the increased risk of neurovascular bundle damage for the greater palatine. Coming on to the flaps in the ophthalmic plastic surgery, the common flaps that we are using in ophthalmic plastic surgery are advancement flaps, transposition flaps, sliding flaps, and the rotational flaps. Flaps can be classified based on the location as local flaps or distant flaps, based on the blood supply as random pattern or axial pattern. Important is in random pattern, the vascular supply is lies on the rich subdermal vascular plexus, while in axial pattern it is directly from the direct cutaneous artery. So what are advancement flaps? In this, the surrounding skin is fashioned into a three-sided flap, which is dissected and advanced on its long axis to close the adjacent defect. Important is the length of the defect to the flap ratio is preferably restricted to 1:3. In rotational flap, these are the flaps which are commonly used in the periocular area, where the directly adjacent skin is lifted over the intervening skin and fitted into the defect. What are transposition flaps? Transposition flaps in this, the skin is not directly adjacent to the defect area, but the intervening skin is lifted and rotated along its own angle. But the important thing is the angle should not be large enough, as it may compromise to the vascular supply. So what is the tensile advancement flap? It can be seen from this image. This is done either for the lower eyelid or the upper eyelid defect, in which we create a semicircular incision and advance the skin for the skin closure. This is the image showing the Cutler beard, which is the bridge flap for the full thickness advancement flap. This is done commonly for the upper eyelid defect in case of iatrogenic causes. Coming on to the next is Hughes tarsoconjunctival flap. This is done for the lower lid iatrogenic causes, in which the posterior lamella is taken from the upper lid tarsoconjunctival complex and the anterior lamella is made with the help of the post-auricular graft area. So what are the common named pedicle flaps in the ophthalmic plastic surgery? Image 1 shows the Fricke's flap. Image 2 is paramedian forehead flap. Image 3 is lower eyelid to upper eyelid transposition flap. Image 4 is nasojugal flap. Image 5, also called as the bipedicle or the bucket handle flap. And image 6 is the islandized superficial temporal artery flap. So I'd like to conclude as what are the different options for free grafts and flaps available, both for the anterior and the posterior lamellar reconstruction. Thank you.
Thank you, Aman, and thank you for finishing on time. So basically, you've covered each and every aspect of the principles of harvesting of the